Very warm greetings. It's an honor to be invited by the 25th Congress of the Asia-Pacific Orthopedic Association. I'm Dr. Neha Gupta, infectious diseases specialist and founder of NG Swasta, which is our venture in Gurugram. And today I'm going to be discussing regarding the antibiotic therapy principles following the debridement and implant retention in prosthetic joint infection and fracture-related infection, which is one of the most dreadful complications following surgeries. So this is my disclaimer slide, and this session is intended for the orthopedic surgeons with an emphasis that an early infectious diseases consultation at the suspicion of prosthetic joint infection or FRI is recommended to optimize antibiotic strategy and outcomes following DAIR. So we know that it's the biofilm which is at the heart of pathogenesis for the prosthetic joint infection. And because of the biofilm, the infections are difficult to eradicate and the infection can be monomicrobial or even polymicrobial. There are stages of the biofilm, and during an initial attachment, which happens within the first few seconds itself, subsequently there can be microcolony formation and biofilm maturation because of the quorum sensing. In the biofilm, the gene expression is altered so that the phenotype changes to a low metabolic activity bacteria with a very high MIC, which can be as high as 10 to 8,000 times. The bacteria inside the biofilm are protected against the antibiotics as well as the antibodies, and that is why we need antibiotics which can penetrate through the biofilm, are cidal in nature. They can act against stationary phases of the bacteria and also have no inoculum effect. That means the MIC of the organism does not increase in the presence of a high inoculum. But yes, most important is source control and removal of the foreign body, which is associated with the maximum outcome. In certain situations, yes, we can also retain the foreign body or the implant, especially if it is an early infection and the antibiotic chosen is appropriate. So there are principles for choosing the rational antibiotic therapy in bone and joint infections, and similar principles apply to the PJI and FRI. First begins with what is the site of infection. So here we are dealing with bone, but even in bone, whether it's a knee or a hip site which is affected, because that will determine the duration of therapy of the antibiotic. The likely organisms, whether it's a gram-positive cocci or GNB, and if it's a GPC, then whether it's a Staph aureus, Coagulase negative staphylococci, enterococci, MSSA or MRSA, the choice will depend upon the type of organism and its susceptibility. Regarding the gram negatives, whether it is Enterobacteria, say E. coli, Klebsiella, or Pseudomonas acinetobacter, or some other organism, what is the susceptibility to third generation cephalosporins, carbapenems, as well as whether it belongs to the group of spice organisms where there can be AMC production. So in the culture report, it may appear that the organism is susceptible, but in reality, these organisms, when exposed to certain antibiotics, may not respond. The properties of the antibiotic, the PK/PD parameters, that we need to choose ideally drugs which have cidal activity and also have adequate concentration at the bone. So beta-lactams, quinolones, drugs like linezolid, levonarifloxacin have a higher concentration into the bone and will be preferred, whereas drugs like polymyxin B, colistin, tigecycline have a limited penetration and not really preferred drugs, or if we have to use them, it should be used in combination therapy. Presence of a foreign body indicates that we have to choose drugs with anti-biofilm activity, rifampicin, minocycline, levonarifloxacin, echinocandins, liposomal ampho B. These have anti-biofilm activity and a higher chances of cure rates. Presence of monomicrobial or a polymicrobial infection. If there are two bacteria, do we need to choose always two different drugs, or we can use one drug for treating the two infections? So here we have MSSA and Proteus vulgaris. This was one of the recent cases. So we chose only TMP-SMX for treating both these infections. So single antibiotic and two very difficult to treat bacteria can be cured. Choose antibiotics which have got minimal toxicity and side effects. So drugs like aminoglycosides, colistins, or fosfomycin, they will have higher toxicity. These are the drugs for gram-negative, so safer cephalosporins. Beta-lactam agents like carbapenems. If carbapenems are resistant, then aztreonam, avibactam, or a combination therapy of ceftazidime, avibactam with aztreonam can be considered. When there is allergy to the beta-lactams, alternative agents for the gram-positive clindamycin can be considered. If there is TMP SMX allergy, so that also we need to choose alternative agents. And remember that if a patient is presenting with fever, is on antibiotics, it may not always be infection, it can be drug fever. So look out for itching as well as the eosinophil count in the CBC. Choose drugs with lesser collateral damage to the gut. Host factors like younger patients can still tolerate amikacin. So if there's a GNP and it's susceptible to the amikacin, we can choose it. Elderly patients avoid amikacin, and amikacin has to be given as a single daily dose rather than twice daily to reduce the nephrotoxicity and have the maximum effect, which is concentration dependent. Choose drugs which may not affect the kidneys or the liver, and of course, whenever antibiotics are chosen, renal dose modification or dose adjustments have to be performed. For choosing antimicrobial therapy, it's important to know that which is the organism. In the West, we have the GPC, which is the most common. However, we know that in India, it is the gram-negative bacilli, which may contribute to close to 70% of all the pathogens. However, we are staying gram-positive as well, which can be MSSA, MRSA, as well as Coagulase-negative staphylococci. Now we see this patient. This is a 42-year-old gentleman who had right leg chronic osteomyelitis following this road traffic accident, and then he had undergone multiple surgeries. In 2017, when he presented, the leg wound grew this Pseudomonas aeruginosa, and this was carbapenem resistant. It was only susceptible to colistin and minocycline, which was reported here. So what do we choose here? Colistin and minocycline alone as a combination, colistin alone, minocycline only as a monotherapy, or something else. So it's important for us to remember that even though culture report may show susceptible, there are certain agents which may not be covered by the antibiotics. And minocycline is a tetracycline which has no activity against the Pseudomonas. So all this, the intrinsic resistance to the antibiotics have to be considered. Even with broad spectrum antibiotic like colistin, bacteria like Proteus, Morganella, Providentia, Burkholderia are not covered. So choose antibiotics accordingly. And in this patient, since colistin was susceptible, but now we will call it intermediate, here it was susceptible, but penetration of colistin into the bone is only 25%. Combination therapy with imipenem was used and he was treated. In today's scenario, we can use a combination of ceftazidime avibactam with aztreonam, or even Vocard 5222 can be a very promising option for the future. Remember to use drugs which have got good bone penetration. Good bone penetration is seen with clindamycin, TMPS mix, fluoroquinolones like ciprofloxacin, levofloxacin for Pseudomonas aeruginosa, minocycline for the Enterobacteriaceae as well as for the Staph aureus, linezolid, rifampicin, levonarifloxacin. Minocycline can also be used for the Acromobacter. There are drugs like daptomycin, colistin, cloxacillin, cefazolin, which have got poor serum concentrations. This particular patient who had PJI had a blood with Staphylococcus aureus. With Staph aureus, we need to look at the oxacillin susceptibility. It was resistant, so this is an MRSA, and teicoplanin was susceptible. Subsequently, the prosthetic joint also had got infected, and this was the Biofilm GI panel which had detected the Staph aureus here with the MEC-A. This was a very difficult patient who had this late onset prosthetic joint infection of bilateral knee joints. This was a community acquired MRSA which was detected on the Biofilm GI panel, as well as the blood cultures were positive. Underwent debridement with implant retention. Initial antibiotics which were tried were the teicoplanin, but there was leukopenia. Initially, subsequently, daptomycin was used, but there were cost-related issues. Then we used clindamycin, but there were GI side effects. TMP SMX, which is Cipran. However, there was allergy to the Cipran. And then, along with rifampicin, there was a severe gastritis. So subsequently, in this particular patient, we tried levonarifloxacin, which was given for almost 4.5 months. The patient tolerated it very well, and this was related to the tolerance, good bone penetration, anti-biofilm activity, and this is also an oral agent which can be used. Hence, this is there's no one size which fits all. We have to choose our antibiotics based on the efficacy as well as the tolerance. So managing infections is a multidisciplinary collaboration, and it's important that we work together. It's the teamwork which is going to be magical, and this is one of the examples of ortho-IT collaboration, which has been a game changer in management of infections. Thank you so much.